Hello, hello. Hi, Chris. I feel like I haven't seen you in forever.
I know it's been way, way too long. It's weird.
Life's been crazy. So I know you had an amazing live stream last week. And I'm just excited for today. I don't even know when was our last time that we had just us.
I don't know. That's why I was so excited. It was like normally we have guests and we're planning for it and we're getting bios and we're like getting topic questions ready. And today I was like, oh, it's going to be the pre-submitted and live questions. This is great. It's just us.
Yes.
Just
We're
us.
just chatting, so it's fun. Well, good. So let's hop off, guys. So as always, please remember that today's live stream is intended to be educational, hopefully insightful, maybe challenging, supportive, all of the above, but not intended to replace therapy. If you are struggling with OCD or mental health condition, we would encourage you to seek out your own professional clinician and be working one-to-one with them individually. And of course, IOCDF nor our live streams are crisis or helplines. If you're feeling unsafe or suicidal, we want you to take care of yourself. So please call 988 or follow the appropriate measures to make sure that you can do that. We are really excited. So as you'll know, our live streams are kind of like a mix. So half of the time we bring guests on and we're doing lunch and learns on specific topics. And then we try to make it, or at least a couple times a month, Chris and I just get on and do two things. Number one, we just chat. Like we just talk about hot topics and what's coming up and what we're seeing and what we're not seeing and go through questions and all of that. So we certainly want to make sure we go through live questions. So today, if you have any questions, please put in the comment pane questions you want us to answer, things that are on your mind, things that you want to learn more about. But we also have a huge list that we could never get through at this point of pre-submitted questions. So we will certainly be pulling from those as well. But let's first just do a check-in, Chris. I want like updates on how you're doing. And I want to talk a little bit about just like what you're seeing in both the clinical world and chatter in all of your communities around like questions or things people have been wondering lately or talking a lot about.
Yeah, no, I'm doing really, really good. I'm about to go to Norway and Iceland. So I'm gonna be gone. It's crazy because I realize like I'm gonna be gone from 3 live streams. So please don't replace me. No, I'm just kidding. But yeah, it'll be hard. But no, personally, I'm doing really, really good. I mean, I don't know if you feel this way as somebody who has their OCD managed. Like, I couldn't travel. I mean, my OCD, I was really afraid of health related scares. I thought going and traveling abroad, there was radiation on the plane. I was going to go through metal detectors and get radiation. I was going to get cancer. I was going to get, all these different foreign diseases if I travel. So I always like these full circle moments when you're in recovery to really say like, hey, this was once unattainable. Yeah. And then I don't know if you felt this way, but I think you get to that point where you start to almost lie to yourself, like, oh, I don't need to travel anyways. Who really wants to travel? And you almost con yourself into thinking you don't care. But now that I'm able to do it, obviously through recovery, I'm just so excited. So that's me personal check-in. But for talk kind of in the field, I had Alec Pollard. He, as you know, he was on our live stream, but he came to our family and loved one support group, the one I run each month. And there was a question that asked, and it said, look, Dr. Pollard, in all your recovery, in all of the years that you've helped people recover from OCD, what is that number one thing that sets people apart from getting better? And he said, without even hesitation, the people that do their OCD homework every day consistently, that's the difference between the people that get better and the people that don't. And so that really rang true for me. So I run support groups, and we really talked last week about the importance of doing your OCD homework, setting time aside to really sit there and do exposures, but even more than exposures, the learning that comes with it, starting to gain things back. And the conversation we had as part 2 last night is that all exposures are not the same. So if you're kind of waiting for life to throw an exposure at you, or you're sort of avoiding and something pops up, that's amazing if you push back and really kind of get through that. But what's more important is dedicating time aside. And both of us run higher levels of care. Yours obviously a much higher level of care. And that's what you're really helping clients do at a residential, is they are living treatment for hours upon hours. And so we were just talking about the importance. We know people are busy. We know we have so many things going on. But if you can really, really, really set aside time to push back on the OCD on planned exposures, that's the number one thing Alec Pollard said sets people apart that get better. So that's been kind of the conversation.
Yeah, I mean, and I think that it's something we've talked a lot about, and you guys know that I've talked a lot about it, that I think so much of treatment outcomes comes down to willingness. When we've talked a lot, so I saw some chatter kind of, I would say last year, the chatter was louder about, is ERP really the most effective treatment and does ERP really work? And I feel like we've done a really good job of helping educate folks that like ERP is the most effective treatment, but also ERP doesn't have to be what you often have those preconceived notions that it is, that it's this like fear factor, grotesque treatment where we make you do the hardest, most disgusting things. But instead, ERP should actually be values based and bring you closer to your values and drive those things that you really want to be doing. So it should be something that, while of course it may be difficult, at the same time, it should feel really good. It should be really exciting. It should be really rewarding, right? Because you're doing these things that you haven't been able to do for a long time. And so I feel like the thing that I see though is that for so many of us, because I've talked about this, but like I was one of those people who was kind of doing ERP halfway, right? I had like one foot in and one foot out. And so I was doing it a little bit, doing some homework, doing some treatment stuff, but I really wasn't doing ERP. Like I wasn't actively entrenched in ERP. And I knew that. Like I knew what I was holding on to. I knew that, oh, if I do these other things, I will see much better outcomes. But I was scared. I was anxious. I didn't want to do those other things. I didn't have that willingness, that push, that drive. And so one of the things that I have found is that I see a lot of patients, and I've been talking about this lately, where they kind of do, or we do enough ERP to be functional again, right? To be able to start to get back to school, get back to work, get back to friendships, but we're also still holding on, right? So we're much better than we were, but we're still struggling with OCD. Unfortunately, I feel like I do see a decent amount of people stop there, right? Where they're kind of like, well, I'm functional enough. And then they start to believe or think or tell themselves, this is the best I'm going to get. That like, well, if I can function, that's really good. And like, that's the best I should expect. And that's a great outcome. Where my push is like, no, right? You should push for so much more and you can have so much more. And so what I would encourage you is that if ERP got you to a place where you can function again, that's awesome. Start functioning. But when you start functioning and life starts to get bigger again, and you start to say, oh, now, even though I'm functioning and doing better, I still wish I could get rid of this part of my OCD or these little things, or I wish I could push in this area. Start pushing. Don't just settle that, oh, well, this is the best I can have. No, that's when you can really obtain freedom. I think that it's like I really do think treatment can be this like 2-tier process where you do treatment to get functional back to life. Then when you get back to life, you become more motivated to work on that remaining stuff that's there. But what I don't like, and what just makes me sad, honestly, is when folks kind of stop at that midpoint, right? Instead of saying, okay, now I'm more motivated to do that final stuff, they are like, oh, well, this is just how it's always going to be. I'm never going to have or be at this place of freedom.
Yeah. No, 100%. And one of the things that you touched on that's so important is we were having that conversation last night, because the group I run isn't only my clients or even clients at the center I work at. We have people that come to our group that are seeing other clinicians. And somebody said, like what was really helpful for me was sort of over correction. And so the person was like, I normally don't, they have POCD, and they're like, I normally am not around kids. I'm like a single 25-year-old. But what helped me in treatment is like deliberately going out of my way to go to stores where I knew kids were and stuff like that. And so a lot of people had confusion over kind of like stepping up exposures or that overcorrection. They were thinking, oh, does that mean that I'm going to have to burn a Bible? Or does that mean that I'm going to have to like, go on a date with somebody of the same sex and like be in a romantic relationship to get used to being gay? And it's like, no, that's not the goal of treatment. The goal of treatment isn't to put people in these fear factor situations that are pure terror, that are against values. What the treatment is really asking you to do is say, look, in life, you're going to get thrown so many mixed scenarios. And we can look at it as one of two ways. We can look at it as pure torture, overwhelmed, anxiety ridden, and distressed, and shut down and avoid. Or we can say, hey, life is going to consistently throw curveballs at us, and that's okay. We're going to be out somewhere and a kid's going to bump into us. If you have harm OCD with a family member, you're going to be eating a steak or an item with a sharp knife at some meal with them at some point. So wouldn't you rather do that in a controlled treatment environment and then practice it on your own terms versus waiting for the world to throw something scary? So I'm glad that you made that caveat that, treatment is supposed to be this kind of like collaborative, beautiful thing. It's not supposed to be this horror show where you dread trying to get better. And that's so important for people to remember.
100%. Yeah, I couldn't agree more. And we had Rich Gallagher come to our clinic last week. So Rich did a lunch and learn for us. Yeah, it was so great. And I loved one of the things that Rich was talking about is kind of this idea of not pushing people too far to where they're not willing to do any of it. And instead, like, is it okay if people are still doing some rituals, but they're starting to re-engage in life, right? And he has this specific terminology and things he talks about in his new book. And you know a lot about that, Chris. And it's interesting because I said to him, I said, Rich, it's interesting because I always talk about how I do believe that treatment outcomes are better and that it's a little bit easier to get somebody to engage in treatment if they're continuing to engage in life, even though they're ritualizing, versus somebody who's avoiding everything. And so I would much rather you start re-engaging, even if you're doing rituals, because then you're going to have more motivation to get rid of the rituals because you're doing things you like, versus if you started to avoid everything and then you're like, well, I don't want to do that anymore. I don't see the purpose. I don't see the need. It's much more important for us to have individuals at a place where they really they're driven, they're motivated because they're like, well, I go out with my friends, but then I'm ritualizing and I hate it and I want to get rid of these rituals, right? That's a lot easier for us to push you than if you're like, well, I've quit going out with my friends altogether and I don't want to because I'm not willing to be triggered by them.
Yeah. And like you said, I tell clients all the time, like, you getting a job, you going out with friends, like you doing things like that, that is treatment. It doesn't feel like treatment because people are used to doing exposures and the cognitive kind of part of the treatment, talking about ACT principles, different cognitive principles, right? Sometimes doing DBT work if needed. So it feels very like treatment heavy. But what we always talk about is the goal, just like Liz just said, is to start to get you involved in things you like, because you need a why. You need to wake up each day and say, this is why I'm fighting. This is why I'm trying to get better. But by getting a job, new things are going to be thrown at you. But like Liz just said, you're going to be in a work environment. You have coworkers that are friends. You're doing something you love and you're getting a paycheck. You are much more likely to do the work. And that's really what, shout out to Rich, obviously his book. I was honored to write the foreword of it. And that was really the work that I saw him putting out there that helped my own OCD, because sometimes with OCD, we get in such a black or white mindset. And it's like, well, I'm not going to do that because I'm not ready, because I can't do it without, any kind of safety behaviors. But as I started to realize, it's like they were planned safety behaviors. It's like, okay, I'm going to go to the grocery store now instead of having my family go for me, but I'm going to go at night when less people are there because it's easier for me. And I started that way. And then it's like, okay, I'm going to go midday where there's still less people, but it's harder than at night. And then eventually I'm going to go at like prime time and really deal with the crowds and people touching items and touching those same items. So it felt strategic, but it was getting me willing to do things. And then you got the satisfaction of being able, for me at least, to be more autonomous and doing things as a young 20-something-year-old versus having my parents still do stuff for me.
Yeah, 100%. And I love this comment from Amy. She said, freedom from OCD is thriving, but functioning well with it is existing. And it kind of reminds me of just how we talk a little bit about just like functioning with it is like you're barely surviving. And so I just want to push y'all, because I think so many times we hear this language, we hear these comments that really make us think functioning is the best we're going to get, right? That, oh, you can, you can really be struggling, but still live by your values. Like, I know what someone means by that. We often mean like you can struggle and still do amazing things. But at the same time, does somebody hear that as, oh, in order to live by my values, that means I'm always going to struggle, but I just still have to live by my values anyways. Like, no, you might have to do that right now when you're in treatment, but the long-term goal is that if you're truly relinquishing OCD, you quit playing tug of war, you drop that rope, right? You're not negotiating with it anymore, and you really lean in. You do that workout Pollard's talking about. You really fight for those things that are important to you. You will get to a place of freedom, right? A place where OCD doesn't occupy your mind or your headspace. And again, that doesn't mean it never comes up, right? Like sometimes I go to the doctor and get a test and my health anxiety, peaks a little bit, but like I push through it. It's not it's not stopping me from living my life anymore. So I still at times have a thought or an experience or a trigger might be a little bit stickier than it would be for somebody without OCD. But it's not interfering, right? It doesn't impact the way I live my life or the choices that I make.
Yeah, 100%. And I always called it the 75%. That's what I always get nervous when a client is at like 75% better. And because they aren't struggling, they kind of tap out of treatment. They sort of don't conclude treatment. They leave some things still out there that maybe they're avoiding. And, I always tell people, just like if you were getting a cancerous tumor out, you wouldn't say, please get 70 to 80% out. You want the whole thing gone. So really pushing it. But treatment is, I always tell people, because people ask all the time, like, how do you know it's the right therapist? How do I know I'm doing therapy right? And I'm like, do you feel like your day to day is what you kind of thought it was going to be when you entered treatment? Are you getting in relationships? Are you reconnecting with friends and family? Are you going on those hikes? I mean, Liz, you and I have been honored to meet so many great advocates, and we see people that have families. We see people that are traveling, that have their own podcasts, that are writing books, that are, talented, that are doing all these incredible things. And it's like, that's what recovery can look like. And I also think, I always say to people, like, ask your therapist, what do they feel like the Achilles heel is right now in treatment? Like, what is that one thing? And have that conversation with your clinician. We're human too, right? So sometimes we have a plan and we think we're doing everything right. And you're like, hey, can we slow down and talk about my obsessions a little bit more? I'm still confused how they're getting me tricked. Or this has been really hard and I don't think I'm doing well and I'm losing steam. Can we move to something else? Make it collaborative, because like I said, you're supposed to help, your clinician is supposed to help kind of identify, like, hey, these are the barriers, but sometimes we don't see them, letting us know as well. But yes, it is all about getting back to that life you want. And I think, Liz, with you leading the charge on this, I feel like it's a much more hopeful message than it was 10 years ago, 5 years ago, about recovery. And it needs to be, because people are getting better and they're doing really well in life.
I hope so. And I love some of your comments saying, like, well, I'm not where I want to be yet and I still have work to do. That's okay. That's actually great, right? That's what motivation is. Like, that's where we want you to push. Like, we want you to say, I'm not here yet, but here's where I want to be. Here's the areas I want to be able to push, right? And so you really start pushing in those arenas. There was a question at 11:10 my time that I would love for us to cover from Spence Robert. He said, I was getting kind of bored during my ERP. My therapist said to fully experience the boredom. Can this be a kind of inhibitory learning? I'll answer this first, and then Chris, I would love for you to answer. But when a patient tells me they're bored, that is when I celebrate. If you are bored, that means you're not triggered anymore, right? If you're bored, you're doing things right. And so when somebody says to me, oh, wow, like, I did this exposure, I've been doing these exposures and it's boring now, like, it's not activating for me anymore, that's when I'm like, amazing, time to move on, right? Let's move on to the next level exposure or the next thing. But we want you to be bored, right? Being bored tells me it's not activating me. Like, it's just an activity, or it's just a boring thing I'm doing, right? This contaminated coffee cup that used to be triggering, now I'm just bored because I'm just sitting here touching it. This is boring. Awesome, right? So I think that's a great sign. What do you think, Chris?
Yeah, no, I mean, that's the goal. By the way, I'm packing, so I can realize that all the stuff right here is messy. So I'm going to just talk.
Yeah, no. So now we can all see it.
Everybody stare, right? I'm packing. Don't judge me. Yes, absolutely. The goal is to be bored, right? Because when we look at scans of the brain, when people are struggling with OCD, what tends to happen is the brain is in conflict. It's firing, and it's loud, and it's tricking us to thinking it's using our natural fight or flight. It's using our amygdala and all those different components of the brain to really tell us, like, hey, Chris, drop what you're doing and handle this, ruminate, figure it out, wash it, clean it, avoid it, right? And so part of the treatment is to be able to experience it. And if part of that experience is boredom, that's a good sign. Because, for me, brushing my teeth used to be an event, right? Because I was worried about blood. And what if I get blood in my mouth by flossing too hard? I don't even think when I brush my teeth, and I'm listening to music and kind of, just doing whatever. Normal activities are supposed to be boring, right? They're only active in our mind because of the OCD. Now, what inhibitory learning teaches us is that our brain at one point kind of put this, this thing like brushing your teeth in the not safe category. And after we do the treatment and we get better, our brain starts to put brushing your teeth in the safe category. And you start to realize, like, hey, brushing my teeth is kind of a neutral event. So it's definitely a good thing that you're experiencing that, because it just means that you're getting to the point where it's no longer causing some kind of negative visceral reaction. And that's what we're really looking for.
100%. All right, let's keep going through questions. So next question at 11:13. Sorry, somehow you guys, my laptop is on like a bigger screen that it plugs into, but the audio doesn't work. And so I have to disconnect it. So it's so bizarre. I'm sharing all this with y'all. But when I disconnect it, everything is like tiny size. So I have to like look in to read the questions because like it's supposed to be on the bigger screen. 11:13. How do you deal with OCD during the night as intrusive thoughts come up? I get consistently harassed by the thoughts of eye pain while I'm trying to sleep as my eyes initiate sleep and rolling. I don't know how to detach.
Yeah. So what I would say,
I'll just share, this is a type of intrusive thought, and sometimes I check to see if my eyes are still okay. It's troublesome when you're trying to sleep and your brain goes, are you sure your eyes aren't bleeding?
yeah. So for a lot of people, some people will say the morning is the hardest. They wake up and they sort of get like infused with all these different thoughts from the day. And other people say it's at night. And part of the reason that at night it hits pretty hard is because we're laying there, we're not distracted by other things. And all we're doing is kind of sitting there and thinking. So the hard thing is like that's usually, and we're tired and our guard is down. So in this case, what OCD is doing is it's saying, hey, notice their eyes. Are they in pain? Do you feel pain? Notice that eye pain. Could they be bleeding? And I get it. You are tired. It's the end of the day. You just want to be done. But the problem is if you give into it, just like we give into, a spoiled child, or if we, give into our pets and we keep feeding it human food and then it won't eat, dog food, for instance, it's going to demand more. And what you'll start noticing is by making that decision of answering it, of getting involved, what you'll start to notice is that every day it gets louder. Why? Because you're reinforcing that something's wrong. So the most difficult part is separating the O from the C in OCD because it happens so quick. The obsession here is, do you notice that eye pain? Are you experiencing eye pain? You should be focusing on this eye pain. Could it be bleeding? That is the demand OCD is making to you late at night. Now, your choice and your strength is how you choose to respond and react. If you get worked up, if you're checking and going in the mirror and looking at your eyes and you're like, leave me alone, I can't sleep, this is driving me crazy, you will be amplified, your fight or flight will kick in, and you will struggle to go to bed. And bed will start to have a association with negativity, and then you'll start dreading bed and all that. If it's happening during the day, obviously you can totally start to push back against the OCD throughout the day. So when we have those somatic obsessions, what OCD is really trying to do is drive us in a state of frustration because of our hyper focus of that. So a couple techniques could work. You could take the more mindfulness technique where you acknowledge that there's a hyperfixation on a body part, is a sensation, whether it's your eyes, it could be your breathing, it could be your swallowing, and sort of note that and notate that and be aware that it's popping up, yet still choose to redirect your attention forward on the things that are important to you. Or you can take a more aggressive response. There's a really good section of this in John Grayson's Freedom from OCD book. And what he talks about is you want to initiate the hyperfixation of your somatic experience. And he talks about a technique of putting sticky notes up and writing a word or putting a dot to remind you. So anytime you're relaxed, you look at that sticky note and you're like, oh yeah, I'm going to notice the sensation of my eyes. When you choose to initiate, when you choose to be the aggressor and be the offender, that part of you that's so frustrated from having the hyper focus on your eyes gets taken away because you're the one who initiates it. So with a trained clinician, I would start by deliberately bringing on the thoughts, the feelings and sensations yourself at night, because that will really take away that frustration that's probably keeping you up and making you even more exhausted.
100%. Next question is from Amy at 11:18. What is your motivation for taking on the OCD bully / dictator? Use that to face the fear, OCD scams?
Yeah, I mean, I think all of us need to have a motivator. I mean, sometimes it doesn't have to be grandiose. I think mine was just simply, I had a really good life prior to the OCD hitting. Maybe not a great life. I had a lot of other stuff going on when I was younger, but at least there were certain things I enjoyed, and I felt very sad and very frustrated that I lost that. But I think it's important for everybody to have motivation. Are you a parent? Does OCD take time away from you and your kids? Are you in a relationship, and because you're doing compulsions, you're not getting to go on dates or spend time with your partner? Are you running a company, a small business you've always dreamed of, and you're finding it harder and harder to get the work done? Did you used to be really engaged in pickleball with friends or tennis or volleyball, yet you can't even get back on the court? So I think part of it is just really finding, like, what have you lost? John Grayson talks about that as well. It's like, what have you lost due to the OCD? And really kind of focusing on that. And I think motivation is important. Having small, very reachable goals is important, and keep moving forward towards that life you value, because that's going to be your organic motivation once you start to see success and get those feelings of accomplishment.
100%. Next question. At 11:22, how do you deal with same time OCD or backfiring of an exposure? A couple said bye and I wasn't going to hug them, and she went in to hug them and I did. Then I was like, I'll need to hug them, which is fine.
Yeah. So what it sounds like is same time OCD or backfire. So I'll kind of look at those separate. What I think you're asking, Alex, and you can always correct me, is like, how do you deal with an exposure you're not ready for, right? So a couple says bye and you weren't going to hug them, and then they did. And then you're like, okay, I need to hug him, which is fine, right? What happens sometimes is we're not prepared, right? Like we are, a client was just talking to me. They had their purse on a table at a restaurant, and the waiter came over to drop off some bread and butter and like moved the purse to put the food down. And my client was freaking out. I have to throw away my purse. I don't know where their hands have been, etc. You're going to get those moments where you're not planned for a couple going in to hug you. In those moments, the best thing you can do is let go, let go, let go. It's about acceptance. It's about being passive, and it's letting it happen. We are so used to pushing back, avoiding, compulsing, that when something like that happens, it's embracing it. So what this client did, which was really effective, is she just said, you know what? My purse was moved. I can't go back in time. I don't know exactly what touched it, and I'm not going to spend time trying to figure out. And I'm going to continue to use my purse as is. By letting go and moving forward and not engaging in the OCD, they were able to move past that versus spending the whole meal fixating what was on their hands, what could they have touched, answering questions that they'll never get the answer to. As for backfiring, sure, sometimes that does happen. And I'm glad you brought it up, because this was another conversation we were having yesterday. Sometimes either, you're going to go out and you're going to go to a restaurant for the first time and you end up leaving. It's too hard. Or let's say you go to the restaurant and something happens and it's just too hard and you leave. Sometimes people think of that as a stop sign. I need to give up. This was too hard. I need to never try this again. I instead look at it as a yield sign. It is time to pivot. Maybe that exposure was too hard. Remember, a little E and a big response prevention is more important. So if that restaurant was too difficult, maybe you can walk into a fast food place where you run in and grab food and leave. Why don't you try that? Maybe you did the exposure and it backfired. Pivot. Yield, work with your clinician to figure out what didn't work, so that both of you guys could then create a plan on what to do next time that would be more effective. So don't beat yourself up. It is a process. It's a journey. It's okay if it didn't go the way you had hoped.
100%. So many folks are saying thank you and talking a little bit about their own OCD. At 11:27, is this a real life? Are you guys real? Is there proof you're real? This is real life. We are real. But, if you're having thoughts about, of course, if it's OCD thoughts, existential OCD, we want you to work on it that way. But if it's other thoughts, we want you to get appropriate treatment around that as well. Next question is, living with obsessions in recovery. How do I manage the exhaustion of the constant nature of intrusive thoughts while letting go of compulsions?
Yeah, I first want to validate your experience, Ashton. We had this conversation, at group last night as well. As somebody was just saying they're tired, they're exhausted. We were discussing some of the barriers of doing treatment, and that was one of them that came up. Was just, I feel like it's so much. I'm exhausted. I'm tired. I'm tired of trying to learn things about OCD, figure out why I have these obsessions. How are they created? Why do I have these specific thoughts? These are the really tough compulsions. Values, what are my values? It's an exhaustive experience, right? So what I wanted to say to them, and what I'll say to you, Ashton, is giving into the OCD is exhausting, right? Spending every day waking up and figuring, okay, who's going to touch this? What if this thought comes up? What if this person comes into my house? And what if this person does this, right? When we have OCD, we are on a constant state of alarm. We are scanning for trouble. We're scanning for problems. We're coming up with ways to reverse that thought, clean that item, drive back around the block. I think awareness is so important. And so really logging, what I tell people in the beginning is don't make any changes, but start to log what a day in your life looks like with compulsions. It has become so second nature for us when we give into OCD that we don't see it as exhaustive. We see the treatment as exhaustive because it's something new. What all my clients come back with is they're like, holy crap, Chris, I'm spending 4 to 5 hours in my head each day, not getting answers, just spinning. I'm spending 6 hours a day doing compulsions. I'm avoiding. I put a lot of effort into having OCD. So I tell them, what about flipping that? At least you get a payoff. So sure, that beginning process of starting to push back against our obsessions, not giving into rumination, doing exposures can seem exhaustive, but you're already doing that for the OCD. At least you'll get a payoff. So starting to notice that the work you do to get better is actually going to give you the relief you seek. And there's a payoff and there's a prize at the end, which is your life. Whereas all the energy you're giving in Ashton on a daily basis to the OCD is exhausting. But sure, own it. It is unfair. We all have OCD. It's not fair. There are days you get to be upset, right? I feel like we all need to like throw and break plates and just be like, I'm so mad I have this. But remember, good treatment is out there and you will get the relief you want and you'll be able to process and move forward and be appreciative of all the hard work you put in to get to where you need to be.
100%. Couldn't agree more. And so many folks are talking a little bit about just some of their own personal examples and going through that. I will just add on, remember, it doesn't have to be exhausting. Like if it's exhausting, my push would be, have you dealt with the core fears or have you just done surface ERP? And we've done a whole webinar on this that you can look up, core fears. But, you know, if we're doing surface ERP, which means that we're constantly just doing ERP for all of our triggers when they come up and when we have them, it is really exhausting and draining. But if you're addressing what's at the core fear of like why you even get triggered by that, why you get triggered by this new situation, and you dissolve and address that, you will see freedom. And it shouldn't feel like it's this exhausting process. If it feels like you're constantly playing like, I don't know what you want to call it, but like ping pong or whatever, but like with your intrusive thoughts and whack-a-mole, we need to slow down and figure out what we're doing, because treatment shouldn't be something that we're constantly just going every day and like, or every week, and it's a new pattern or a new theme or a new trigger. If that's the case, then we haven't actually addressed what's at the core.
I'm glad you brought that up because my answer was incomplete without that. So thank you. I agree. It shouldn't be exhausting. I think the difference is when you're chasing obsessions and compulsions, it's exhausting. It's whack-a-mole. If you really look, I think one of our best webinars was with Michelle Massey about core fears. It's done extremely well because I think it's important. When you start to identify what's underneath, right? A core fear is like, what are we afraid of happening? What do we think is going to happen to us? Who do we think we're going to become? Who are we afraid we are? Like all those deep things, it starts to, you know, string together why all your obsessions seem to be the same theme. And by really tackling those core fears, you're starting to get out ahead and being more offensive. And that helps take away that exhaustion you may be having.
Totally. Next question is, what is the relationship between limerence and our OCD? So I have to tell you, I had to look up limerence because I didn't know what that meant. So I put it in our private track, Chris, but it's limerence is a state of mind which results from romantic feelings for another person and typically includes intrusive, melancholic thoughts or tragic concerns for the object of one's affection, as well as a desire to form or maintain a relationship with the object of love.
Yeah, no, I had a client bring up limerence like 2 years ago, and I will be honest as well, Summer, I had to look it up those years ago. The way I always get really fascinated, like clients have brought up maladaptive daydreaming and different themes and topics, obsessional slowness, processing disorders, right? And I always kind of research and get into it and everything. And you could correct us, Summer, but everything that I looked into when I looked at limerence is it's more of a pleasurable experience. Sure, it can be frustrating because you start to kind of create almost this like romantic relationship in your head or this friendship of a person. And you start to get to a point where sometimes it can be frustrating because you sort of have this like relationship or this experience in your head and it's not quite happening to fruition. But everything that I read and when I've had clients that have talked about it, et cetera, it seems to be a more pleasurable experience. Relationship OCD isn't really pleasurable, right? So limerence, for instance, could be, I had a client who had sort of feelings for somebody at school and they imagined themselves like, you know, because they had a class together. So they would try to like hang out with the person in class and they, you know, used to have positive thoughts about him and would daydream about him and stuff. And they would get frustrated frustrated. So like, Chris, I don't think he likes me back, and I really want this relationship. But it was kind of in that realm of normalcy. I felt like if that client was to talk to their friends about it, their friends would relate. Relationship OCD is a very different beast. It's where typically we're either obsessed that this isn't the right relationship, I'm wasting my time in a relationship, and it could have me miss out on better relationships in the future. It could be that you might cheat on your partner. It could be that your partner is going to fall out of love. So there's a lot of fear there. There's a lot of discomfort. There's a lot of doubt and frustration. So a lot of times the way that I always come back is back to the basics. Relationship OCD causes that distress that we see typically in OCD, a need to get answers, doubt, a lot of uncertainty that people can't tolerate of the future of a relationship. Whereas limerence, you may not even be in a relationship with somebody, but you have kind of these romantic feelings and desires and affection. It's just like when clients ask me the difference between daydreaming and rumination. Daydreaming can be fun, where you imagine yourself with a yacht, on the Mediterranean seas, where rumination is where you're in such dire need to answer questions about the uncertainty and doubt that you spend so much time staying up at night and can't sleep and frustrated. So it's really that difference between, is it bringing you joy, or is it a pleasurable experience versus distress and unhappiness? And you might have both. Always remember that too. Some people have both.
Yeah, exactly. And again, I think this brings up a really good point, just because I feel like sometimes when we're like having intrusive thoughts in general, or even just thoughts that are like sad thoughts, or maybe confusing thoughts, or maybe thoughts that of like just inquisitive, right? We're just curious, trying to understand something. I think sometimes for those of us with OCD, when it's thoughts that we don't want to have, we automatically will label it as an OCD thought. And sometimes it isn't, right? Sometimes it's actually like, okay, like we don't need to, I'll give a random example, but I was kind of like taking it easy the other morning and hanging out, running a little bit late, but just relaxing with the kids. And I was on my phone. And Grace, we don't let our kids like use phones. They're tiny. And so Grace came up to me, she's 2, and she was like, I want one of those. And I was like, you want what, Grace? She's like, I want one of those phones like you have. And I was like, well, you can't have a phone. You're only 2 years old. Like, what do you mean you can't have a phone? She's like, but I want one. I want one of the phones. And I left for the day thinking, oh my gosh, like such a good reminder that I just shouldn't be on my phone around her, right? That of course she wants a phone. She sees mom sitting there on her phone. And how can I tell her no, and that she shouldn't use a phone if I'm sitting there on mine? And I got to thinking about it, and thinking about how in the past, maybe my OCD would have started to latch on to like, not even OCD, because it wouldn't have been OCD, but maybe like my mom guilt or shame or depression would have latched on to like, I'm a terrible mom, and I can't believe I was on my phone around my kids, and like I shouldn't be a mom, and I'm like, it could have gone down this whole path. Or I could go down this path of like, oh, I'm like, who cares? That was irrelevant. But instead, the path I went down was actually really healthy, which was, I need to be more thoughtful about my phone use around my kids, right? Because when they see me on it, it's not helpful. And it was so interesting to me, because in the past, I always would be so black and white. Like if something made me feel kind of guilty or made me feel bad, I didn't want to think about it at all, right? I didn't want to be uncomfortable. And it was like, oh, I'm just not going to think about that. Or, oh, that doesn't matter. I don't need to be thoughtful. Versus like, no, actually there's a healthy, like, can you learn from this? And is there still something good that's important to learn and that you can grow from? But not get to the place of this black and white where you go into this depressive cycle that you beat yourself up and you feel guilty and horrible and like a bad person over something that was just a normal behavior, right? And so in the OCD world, I want us to think about it similarly too, which is that sometimes when we're in relationships, we do have questions. We do feel confused. We do get frustrated, and that's okay. That's normal, right? But with OCD, it becomes abnormal, right? It's really you have a certain feeling, but your OCD saying maybe that's not true, right? And putting these feelings of constant doubt, constant triggers, not an occasional doubt that pops up that would be normal for us to have.
Yeah. Summer went on, thank you. And then Summer went on to say, I think my limerence does have a root in ROCD. Makes me wonder if I think or talk about my partner too much. That was at 12:37. And I think that's important. It's just exactly what Liz said. And there was a comment by somebody in the chat that said, not everything is OCD. now I can't find that comment, but somebody made oh, it's Stasia. So yeah, so Summer, I think part of it too, I think that goes back to like the core, right? How do I know if something is OCD or not? And I think it's always going back to the basics, right? If talking about your partner brings you pleasure, you don't feel urgency behind it. There's not this ulterior motive, right? Like, oh, if I talk about my partner, I feel better, or it's not causing distress in your life, or you're not getting feedback from your friends and family that are like, Summer, you're doing this too much, right? Or like you're neglecting things in your life, right? That's why we had that D at the end of OCD, disorder, right? Is it causing problems, distress, frustration, losing time at school, at work? If you're in class and you can't think of anything else but your partner, and you think about them too much and you can't focus on classwork, and you feel just this obsessive need to consistently think about them, talk about them, etc., then sure, you're recognizing that behavior is causing distress and you can make a pivot. If nobody really gives you feedback about it, it doesn't disrupt anything, and you're just happy to be in a relationship and like talking about them, and you're not getting any internal or external feedback that it's causing problems, and it doesn't feel urgent and pressured, be happier in a relationship. It's single town over here. So congrats to you, Summer.
Let yourself be in it, right? And enjoy those moments. All right, Chris, we had some previous submitted questions, so let's hop to those. So one of them is, why are therapists only licensed to treat in the states where they live? We see all you great therapists on podcasts who we can relate to, but we live in different areas, so we can't see you guys. With virtual therapy, you would think it should be available.
Yeah, that's one of the most stressful things in our field. It made sense to be licensed in a state pre-pandemic where people, would come and see you at the office. And the only way really to do out-of-state therapy was not really HIPAA protected. I mean, this was many, many, many years ago where, people would do Skype or a phone call or things like that. And unfortunately, like if somebody was injuring themselves or harming themselves on a session, you didn't really know where they live. I mean, it just wasn't very common. I never even thought about it pre-pandemic about working with a client out of state because everything was in person. What happens most of the time is laws are always lagging behind need and where we're at as a society. So sure, I always tell people, like, if I was to see a client in Arizona or Nevada, they probably live closer to me than somebody in Northern California. But what I do know is there's a side pact for PhDs for psychologists, where there's certain states that have come together, made agreement that people can work in different states. States are becoming easier to get licensed in. I know with a California license, because our requirements, along with New York, are some of the most rigorous in the country. I can see clients in states like Colorado. It's easy to get licensed in Florida. I think I could see clients in Alabama. I mean, there's some places where I don't even need to apply for a license. I can still work with them, sometimes limited capacity. So I always say the best thing to do is to reach out to your clinician that you're interested in seeing and see if they're licensed in other states. Or sometimes what clinicians will do is they'll get licensed in another state if it's pretty easy to work with you. I know I'm also a counselor besides a therapist, and I know a counseling agreement is coming out next year where people that are APCCs or LPCCs are going to be able to work in certain states that come to agreement. So the good thing is things are changing. It's just happening extremely slow. So just hang in there. But the biggest thing is to talk to clinicians. Sometimes people don't realize that a therapist that they like is licensed in more than one state and can potentially see them.
Totally. Yeah. So, and a lot of it is really around safety too. We need to know local resources, and we need to be able to get people the help that they need, that in different states, we may not know that. So, all those things there.
There was another question, and I saw it in the chat as well. Is like, in general, how do you deal with intrusive thoughts, doubt, and rumination? Like, what are some basics, Liz? Like, if somebody's dealing with intrusive thoughts, they're having rumination, they have doubt that they're living with, what is just an overall best way to address some of that?
Yeah, no, it's a great question. I think rumination and intrusive thoughts can turn into compulsions, right? So those are your triggers, those are your obsessions that, again, the way we deal with them, first of all, is being able to really identify how are we responding to them? Are we responding rumination? So first you have these intrusive thoughts, but rumination is a ritual, right? If we're ruminating, trying to figure this out, trying to solve, trying to understand it, we're ritualizing. And what we all know is that as soon as we start ruminating to try to feel better, we often end up feeling worse. We're stuck in this cycle and it becomes this never ending kind of loop, right? We become continuously triggered. And so we really want to be thoughtful about that. We want to be thoughtful about the way rumination feeds your intrusive thoughts. And it is literally like adding gasoline to a fire, right? Every time you ruminate, you are continuing to send that message that this intrusive thought might be real. It's scary. I need to figure it out. I need to solve it. And what we want you to constantly do is send the message to OCD that like, oh yeah, like, thanks for giving me that thought, but not going to do anything about it, right? I'm not going to feed it. I'm not going to try to solve it. I'm not going to make it bigger. So be really thoughtful about that. I think that the other piece, just because we had a lot of other questions on our document about core fears, is again, I think sometimes people think that we constantly have to engage in like rumination disruption, right? We get these intrusive thoughts and we need to like disrupt our rumination or not get pulled into it. Yes, that's important in the short term, but in the long term, I want you to be able to have thoughts that actually don't feel intrusive. Imagine if you had even random, violent, scary, random thoughts like everybody gets, but they're not triggering to you anymore. They're not intrusive to you. They don't activate you. They just are a thought that you can kind of laugh about or say whatever about. That is the goal, right? The goal is not that you constantly are having to respond or choose to not respond and feel super activated by your thoughts. The goal is that we can reduce the power that the thoughts have. And if we're doing appropriate ERP, the power of your thoughts should decrease, right? We should start to strip the power away, but also the frequency in which they come should significantly reduce.
Yeah. And I would just say the biggest thing too is remember that an obsession is kind of the first touch point for the OCD. Did you leave the stove on? The rumination becomes a C, a compulsion. So if you're worried about, the stove 5 hours later, that's not really an obsession at this point. It's you taking that thought and kind of stewing on it and becoming a compulsion. So you have more power to stop engaging with OCD than you think. Another pre-submitted question, Liz, is are there any programs for school teachers and counselors to help them recognize OCD symptoms, encourage early intervention so that a higher level of care may not be necessary?
Yes, yes, and yes. Please go to anxietyintheclassroom.org, so AITC.org. And if you haven't, please watch the recent live stream. So there was a live stream with Denise Egan-Stack and Chris and others on anxiety in the classroom where we talked a lot about back to school anxiety and the resources that are available. But this is an incredible tool, an incredible resource that IOCDF has funded and created and has made just for this reason. The point of this is for individuals to learn more about anxiety, about OCD, the way it presents. And the website is broken out into kind of categories for individuals, for family members, and for educators. So it's really great and it's an incredible tool.
Another one is, how do you work with an 11-year-old with extreme OCD who is triggered by my use of words, scratching myself, pointing, and her compulsion is to tap her teeth and spit at me?
Sorry, I'm just rereading this.
No worries.
Yeah, again, so this is a tough question because it feels like the responses have become behaviorally difficult in your household probably as well, right? I can imagine that if a child is spitting at you in response to certain triggers, that is very both, I'm sure, triggering to you, but also disruptive in your household. And so the first most important thing I would want to say is that you really want to create household norms and rules, right? So we don't want to allow somebody, because they have OCD, to be able to do certain behaviors that are not just disruptive, but that would be problematic if they did in the classroom, if they're doing at home, if they're doing to family members. So we want to set some really clear boundaries about things that are and are not allowed. But again, if it's OCD, so if this is an OCD trigger, a certain word that triggers her, that then she's responding in this negative way because she's anxious and triggered, we want to be able to address that trigger. So you want her in therapy, working with a clinician, getting at the core fear of why are these words triggering, right? And we want to be able to make it where these words are no longer triggering. These words are no longer activating. And so we really want you to do that together with a therapist. If your daughter is not seeing a therapist, I would recommend that you see a therapist. If not, to start to create an appropriate game plan to address it. And the therapy I would recommend for you as a parent, it's called SPACE treatment. It's all caps SPACE, and it's a wonderful intervention by Ellie Leibowitz. I definitely want to have Ellie on soon, so let's mark that as a great webinar for us to have. But it's really a specified protocol for parents of anxious children. And it's an incredible protocol that clinicians are trained in. They can become SPACE trained or SPACE certified, where they can learn how to appropriately teach parents how to start to reduce these problematic behaviors and change the relationship in the home.
Well said. This next question, I can't read the whole thing. It was pre-submitted. It was really, really long, but I'm going to summarize it because this comes up a lot. So this was a pre-submitted question, and they said that when they were about 11 or 12 years old, so very young, they watched a movie and there was a scene on how to kiss on the lips. And so at 11 years old, this person showed their sibling, who's 4 years younger than them, how to kiss, right? They were kind of recreating the scene that they saw. Now, this is about 15 years later, they're 26, and the thought came back up about that experience. And they've been struggling with this obsession for about 2 years. Did I cause trauma to my sibling? I want to say sorry, but I'm embarrassed about bringing it up. I don't, want it to be compulsive. I'm confused. Is this OCD? How do I investigate my brother's opinion on this incident? So that's one thing I hear a lot, Liz, for this kind of like real event, false memory OCD, is where someone did something when they were extremely young. They don't think about it for all these years, and then it hits them. And then for like 2 or 4 years, I need to call them. I need to DM them on social media. Are they sad? Oh my God, they're crying on their story. Is that because of what I did all those years ago? How can someone navigate that experience?
Yeah, it's a great question. And again, we want you to navigate this together with your clinician. We have done some webinars on real event OCD, so I definitely recommend checking those out. And this is a perfect example of something we actually talked a little bit about earlier, is that, you don't have to get to a place where when you are reminded of situations or scenarios that you kind of feel guilty about, or that maybe you wish you didn't do, we don't need you to be to a place where you're like, oh, I did nothing wrong, I would do that again, there's no problem with that. Like, maybe you really are like, I kind of wish I wouldn't have done that, right? Or I wouldn't do that again now, or gosh, like, why did I do that, right? Who knows? But the reality is that we can't change these kind of smaller, like these situations, right? Again, and I say smaller just because I think that it's different if we're talking about like sexual abuse or something else that happened, that we need to really be working with our family system, with other individuals, with clinicians together. But when we're talking about incidences that kind of come back up and we're triggered by this, what we call real event that happened in the past, but it's an event that we weren't really triggered by for a long period of time, but then we had this memory that brought it back up. We at that point want to be able to kind of work through that. So process it, right? It is okay to be able to talk about it with your therapist, process why you feel guilty about it, what happened, and make a decision about what you're going to do about it. So are you going to talk to your sibling? Like, yes or no? Are you going, like, what are you going to do? I want you to make a decision instead of staying in limbo of like, I maybe I do need to call them. Maybe I don't. It's like, we're going to make a decision. Like, do you think you should call them? Yes or no? Do you think you should talk to them about that? Yes or no? And let's move on. If you do talk to them, we want to make sure we're not letting OCD run that conversation, right? So not a ton of reassurance seeking and a ton of questions, but instead being able to kind of script that maybe together with your clinician and be thoughtful about it. If you decide not to, then okay, that's the decision you made. You're not going to talk to them about it and you're going to move on. But what we want to make sure we're not doing is engaging in OCD rumination or checking behaviors. So examples of this would be, like Chris mentioned, checking social media all the time to see if they're talking about something that could be related to that experience. If they're seeming triggered, checking in with them to ask what it's about to make sure it's not about that experience, right? Anything you're doing like that is just re-empowering that past event. And so again, what I always say is I want you to remove OCD and make a decision about what you're going to do. And then after you make that decision about what you're going to do, we're going to move forward and we're not going to let OCD continue to dictate that past event or our future events or interactions with that loved one.
Yeah. I think the biggest thing is OCD will add more confusion. And so the more compulsions you do, the less clear you'll be. And then people will spend 5, 10, 15 years trying to remember the exact details of an event, and you can't, and it gets blurred. 2 quick last questions. One is, what would be a technique to address the subtype of OCD, existential OCD?
Same technique as all OCD, right? ERP, exposure response prevention, is the most effective treatment for any type of OCD. Yeah, it looks a little bit different. It's applied a little bit different. But remember, the point of ERP is we start to allow ourselves to have these anxious thoughts, to have these triggers, to learn to tolerate them without being afraid of them, and to choose not to respond to them. So to not engage in rituals, rumination, and trying to figure it out, solve it. And so the same goes for existential OCD. When you have these thoughts, it's allowing that thought to be there, maybe even saying the thought out loud, naming it, talking about it with a friend, a coworker, no, not for reassurance, but like talking about it with a colleague or clinician, whoever it might be, but not responding to it, right? So like, like, I'm having these triggers that this isn't real and we're not having a real conversation right now. Like, you don't need to say that to friends because that could become confessing. But if you're just saying it to yourself, and I'm going to choose not to figure that out, like, who knows if that's true or not, I'm going to keep moving on, versus, oh my gosh, is it real or is it not? Chris, is this a real environment? Are we having a real conversation, right? That sort of thing would be feeding our OCD.
Yeah. And I would say too, the biggest thing I see with this is where people just give up on things they're interested. They're like, well, if this is all fake, why do I even do anything? So be on the lookout for that. This is a sweet comment. So I wanted to say, it says, hi, Chris, I had no idea that you have hearing loss. Yeah. I mean, I don't have 80% of my hearing in my right ear, and I've lost about 15 to 20% in my left. Have you thought about learning American Sign Language? So I've learned the alphabet, but I don't know much more than that. I know like plane and alligator. Actually, how I survive is I read lips.
An alligator? Why alligator?
Because when I was learning the alphabet, it was like the easiest word. And then I was like, okay, I know the alphabet, that'll get me through. But no, I actually read lips. That's why the pandemic was very hard for me with masks, but that's how I get through. So I always tell people, if I meet you in person and it's loud, I'm not staring at your lips for other reasons. It's because I read lips. Thank you. We need great clinicians, as you are. That's so sweet. I did go through the BTTI for training in OCD. It was really great. The only thing is I was at the beginning of my journey as a LPC, and I wish I could go back and go through the training again now that I have more experience. I know that. And then the question was cut off. What I was just going to bring up is, if you are a clinician, in October, in the end of October, there's actually an advanced forum BTTI. So if you've gone through, they didn't leave their name. I wish you did, because you said so many sweet things. So I want to thank you for that. But the reason I brought up this question is because make sure you check out the advanced forum. If you go on the IOCDF website and you look up the BTTI, there is an advanced forum, an advanced training this, I think it's October, the weekend of October 26th. So it's going to be case studies. It's going to be more complex cases. So you can always go back to that. I don't know if people can go through the original BTTI again, but you can always have access. I'm sure if you reach out to the IOCDF to slides and notes, they can send that. But we're so glad. Liz and I are always excited when people are going through the BTTI and getting trained and becoming an OCD therapist. We need more of us. So please check out the advanced BTTI.
100%. Yeah, this was a great.
One more question, or do we gotta go?
Go for another question.
All right, this is for you. It is from Deck Weber at 1252. I'm not sure if this question was already asked, but how can a person with OCD know if the thing they're obsessing about is OCD or a legitimate concern? In some instances, it's not always obvious.
Great question. So my biggest answer that's quick to this is urgency. Oftentimes, if we are feeling like this is really urgent, I have to figure it out, I have to know right now, it's probably not something you're just trying to like understand and solve, right? It's probably anxiety driven, right? Anxiety makes things, and OCD make things feel urgent, immediate, dangerous. We need to know the answer. We have to solve this right now. And often we'll say things like, I can't do anything else till I figure this out. Where with a genuine question, right, it's often much different.
Really well said. The last comment to take us out, somebody asked, Miss Love at 1248 said, what is it like to not have OCD? Liz and I wish we knew. We'd tell you, but we can never answer that question. I mean, both of us have it managed and our lives are so full. But I always say this because a lot of my clients feel shame and stigma for having a mental health condition. So many other people have mental health and physical conditions. So please don't feel like you're different or abnormal or strange because you have OCD. But thanks for coming. This is what we try to do here at the live streams, is build a community so you don't feel alone, but you can get in recovery and live a life that is nothing like it was when OCD was at its worst.
100%. I think that I probably wouldn't meet criteria for an OCD diagnosis because my OCD is so well managed. So I guess I could technically say like don't have OCD in the sense that it's not active in my life, but it certainly is dormant, right? It could become active. It could become triggered in different ways, but it's very, very well managed. And I just love the example you shared at the beginning, Chris, and we'll leave with that, which is like the exciting news of being able to do things like go and travel and things that your OCD told you couldn't do previously and that you started to believe you didn't need to do, but instead you're going to go do it, right? You're going to go have that fun trip that previously would have been really difficult. And I hope you're going to go and send a million pictures and have the best time.
I know. I was looking at the calendar. I'm not going to see all of these folks, these great folks again until October 16th, because I'm going to be gone. Next week is Research Roundtable. And then actually, we got to figure that out. Is Research Roundtable next Wednesday or next Thursday now? Is it changing? I don't know. We'll figure it out on the back end. But if we're...
I didn't hear an update. Yeah, I'm wondering that too.
Yeah. So if we're every Wednesday or whatever we figure out, but let's say it's the traditional schedule we have right now, I won't be back on a live until Wednesday, October 16th. So the good thing is still join us. Liz is going to be hosting and she's going to have some amazing guests. She's going to tackle it themselves. So I will miss all of you. If you follow me on social media, you will see me in Norway. That's half of who I am. I'm Greek and Norwegian, but I'm also swinging to Iceland. I told Bjorkensen that I'm going to see his old stomping ground. So Bjorgensen, I always butcher his last name, but yeah, I'm just so excited to travel. It's a full moment for me because OCD took that away. But I will miss all of you great folks. I'll be back for sure October 16th. But you're going to have Liz. She's incredible. She's going to be people on. This was fun, Liz. I always miss when it's just us two, but we got through so many questions. And thanks everybody in the chat for being part, kind of like our third host. You know, all of your questions and your comments were great.
Always so helpful. Love seeing you guys. See you soon.